Identifying who the appropriate patient is for surgery is important. The historical approach was to use BMI. However, endocrinologists and other healthcare professionals are also now considering the advancement of obesity-related conditions such as type 2 diabetes and cardiovascular disease. When patients are referred sooner, surgery yields better results. Recently, the American Association of Clinical Endocrinologists, the American Society of Metabolic and Bariatric Surgeons, and the Obesity Society published new guidelines for treatment of type 2 diabetes that included bariatric surgery. The American Heart Association also published guidelines with surgery included for cardiac disease, highlighting the importance of considering surgery not just for weight loss, but also for obesity-related diseases.
Historically, bariatric surgery was designed to treat obesity and is used to promote weight loss, and there's still a major role for it in that. But in the end, body weight itself is not a particularly strong driver of hard cardiovascular and other outcomes that really hurt people, heart attacks, strokes, deaths. It's more that obesity is associated with comorbidities that then drive those. Diabetes, hypertension, dyslipidemia, and then they cause those things that really matter to people. So, in my mind, the conversation about when to use any therapy in the realm of obesity and its comorbidities should be driven by how much people are afflicted by those more important metabolic conditions. And for surgery, it's which ones are best treated with surgery. So basically all the obesity-related comorbidities are benefited by bariatric surgery to some degree. But the one that really stands out among those I mentioned is type 2 diabetes. Surgery is incredibly powerful at getting rid of that. About 70 to 80% of people with type 2 diabetes will undergo complete remission after, say, gastric bypass. And so it's logical to consider talking about surgery earlier in people with poorly controlled diabetes. And the International Diabetes Federation and several other expert bodies advocate considering surgery for the treatment of diabetes in patients with a BMI as low as 30, rather than the traditional guidelines that we've been using for 25 years that state it should be at least 35 in people with diabetes. A lot of us in the field think that BMI is certainly not the most important, and maybe not even shouldn't be considered as one of the main criteria for using surgery. But still, there are an awful lot of people with a BMI over 30 and uncontrolled diabetes who never even consider surgery and don't know that they have an 80% chance that it's going to be completely remitted, at least for a period of years, if they undergo these operations.
You know, I ask myself, is this a patient who would benefit from surgery? And if yes, what would the benefits be? For a lot of these patients, when you're talking about someone who needs to lose 10, 20, 30% of their body weight, really surgery is the only treatment we have. You know, and I'm saying this as an internist who's not a surgeon. You know, I wish we had a pill I could give my patient who would help them lose that kind of weight. I'd be so much more comfortable with that, but we don't. And so you have to look at risk-benefit ratios. And the sicker your patient, the larger your patient, the more health problems they have, the more they're going to benefit from having bariatric surgery.